My name is Gracie. This is Brooke. She's on the other side of the room. Ventilator-associated pneumonia is a nosocomial, hospital-acquired infection of the lungs. It develops within 48 to 72 hours after endotracheal intubation and mechanical ventilation. The majority of the time, VAP is polymicrobial. Here I have some of the pathogens most commonly associated with VAP. One is Pseudomonas aeruginosa, E. coli, K. pneumoniae, A species, and Staphylococcus. And as the name suggests, this type of pneumonia is directly related to mechanical ventilation. And for this presentation, we will be focusing specifically on Pseudomonas aeruginosa. Pneumonia is an inflammatory response that occurs when pathogens or other foreign bodies enter the lungs. This is the alveoli. Here's the pathogens that are responsible for the infection. And these here, you have your immune cells, which are your macrophages and your neutrophils, and you have your cytokines here that are responsible for the inflammation. Pseudomonas aeruginosa is a gram-negative bacterium. Gram-negative bacteria are responsible for serious infection. This is because they have a dual membrane that provides resistance to antibiotics, and it provides resistance or protection from the immune system of the host. And Pseudomonas is an opportunistic pathogen. This means that it primarily causes disease in people whose immune system or normal defenses have already been weakened. It's common in ICU because of the ventilators that are used. It is rod-shaped and it is an aerobic bacillus. It thrives in moist environments and is commonly found in hospitals. It is also capable of producing numerous virulence factors, including exotoxins and enzymes that damage host tissues. So here we have an actual photo of our Pseudomonas aeruginosa. The last one is more for aesthetics. Here is our rod-shaped appearance of our Pseudomonas. And this here, the blue here, is pyocyanin, which is a virulence factor. Signs you'll see are fever, tachypnea, so they'll be breathing quickly, increased secretions. There will be blood in what they cough up, or just bloody exudate. There's bronchi and crackles, which are sound you hear when listening to the lungs. And you'll hear diminished breath sounds when you're doing your assessment. And there's bronchospasm. When it comes to symptoms, there's dyspnea, respiratory distress. And if the patient was conscious, symptoms would include anxiety, confusion caused by hypoxia, which is a lack of oxygen in their blood, weakness and fatigue. When they have pneumonia, these alveoli are full of fluid. Here's what a normal air sac would look like. These biofilms are difficult to detect and are difficult to treat. And it often fails to resolve even after aggressive antibiotic therapy. The outer layer of the biofilm blocks antibiotic penetration, preventing many drugs from reaching bacteria located deeper within the structure. In addition to this, the biofilms have a drug-tolerant persister formation. On a molecular level, Pseudomonas aeruginosa produces virulence factors that damage tissue and suppress the immune response. Virulence factors are substances produced by a pathogen that help it invade tissues, damage host cells, and evade the immune system. Aeruginosa forms a biofilm that protects it from antibiotics and the immune system as well, as discussed in the last slide. When it comes to cellular, aeruginosa attaches to the cells lining the airway. The immune system, the neutrophils and the macrophages we saw in that one photo, triggers an inflammatory response. These are the cytokines. While this response is intended to fight the infection, excessive inflammation can also damage healthy lung tissue and contribute to worsening pneumonia. When it comes to the tissue level, inflammation caused by the P. aeruginosa allows for fluid to accumulate in the alveoli and for edema to form. Swollen alveoli fill with exudate and cannot properly function for gas exchange. When it comes to the organ or organ system level, infection fills alveoli with fluid and gas exchange is inhibited, meaning oxygen is not moving efficiently from the lungs to the bloodstream. Less oxygen delivered to the body tissue and the patient may cause hypoxemia, difficulty breathing, and increased secretions. The need for ventilator support is increased at this point. Poor perfusion of oxygen can impair the function of other organs and can damage them. The inflammation, the fluid buildup, and the bacteria itself can damage the alveoli, causing fibrosis and reduced lung capacity. This damage can increase the risk for chronic respiratory conditions. Pseudomonas aeruginosa in VAP is more at risk to cause damage due to the lack of respiratory defense and because of the antibiotic resistance. It is more difficult to treat and takes longer to clear, leaving more time for that damage to occur. All strains have an endotoxin, which is a major virulence factor in bacteremia and septic shock. Bacteremia is where bacteria enters the bloodstream from the lungs and spreads to other organs. This can also cause organ failure, just like the hypoxemia can over time. And another thing that could happen, in this photo here, we have pleural effusion. Pleural effusion is where fluid builds up in the pleura. This can become infected and it needs to be drained. Another thing that VAP can cause is lung abscences. This is where pus forms in a cavity in the lungs. Sometimes this may require surgery or drainage. And on the next slide, there's a gross photo coming up. It is a photo I took at the Real Bodies exhibit in Vegas. So this here is a photo of a lung with pneumonia. You can see the damage. The damage is right here in the middle where that white is. That is the damage caused by the pneumonia. Around it is the health, or what would have been healthy tissue, and that will leave long-lasting effects.
When diagnosing VAP, patients are at a high risk for VAP due to their age, sex, respiratory health history, or reintubation. Males over the age of 70 are the most susceptible to VAP. Those patients that have COPD or asthma are also more susceptible as their respiratory health is already hindered. For a correct diagnosis of VAP, we can do a complete blood count test that can help determine if a patient has pneumonia. With pneumonia, oftentimes white blood cells are elevated, mature and immature neutrophils are increased, and occasionally the red blood cells are decreased. For proper diagnosis of VAP, oftentimes a chest X-ray or CT scan of the chest is often performed. A CT scan is more specific in differentiating pneumonia from other lung disorders. Cultures can also be performed for microbe-specific determination. Typically, for mechanically ventilated patients, this would be done via tracheal aspiration or bronchoalveolar lavage. The bronchoalveolar lavage is more effective because it is less likely to be contaminated from upper airway secretions. Knowing our patient's susceptibility, health history, and how to diagnose this disease adequately is critical to the treatment and preventing the high mortality rate. The most important takeaway to prevent VAP is proper hand washing techniques. This reduces the risk of VAP significantly. When a patient is placed on a mechanical ventilator, the patient should be placed in a semi-upright position, allowing for secretions to exit more easily. The head of the bed should be at a 30 to 45 degree angle for adults and 15 to 30 degree angle for infants. Oral hygiene is extremely important, which includes chlorhexidine mouthwash to reduce bacterial colonization in the oral cavity. Subglottic suctioning must be performed daily, which typically includes an endotracheal tube that removes secretions. Reducing sedation daily per the patient's ability and health is also a key takeaway. The longer a patient is sedated and on the ventilator, the higher of a risk for VAP they are. Treatment includes a wide range of antibiotics that are gram-negative and gram-positive, targeting to ensure that if a patient has Pseudomonas aeruginosa or Staphylococcus aureus, it is treated and should be started as soon as VAP is suspected. Once a culture has been done, then it is easier to know which antibiotic to use for that specific microbacteria. If the culture is identified as Pseudomonas, then vancomycin or lisinoid is often chosen. While if the culture shows Staphylococcus aeruginosa, medications such as piperacillin, tazobactam, or cefepime are chosen. If the patient has shown to be antibiotic resistant, additional or different medications may also be given. If a patient shows signs of septic shock or severe illness, triple therapy may be the course of action. Adjustments to the ventilator also help to treat VAP. The ventilator should be adjusted to improve oxygenation and decrease the workload on the patient. When given vancomycin, there are a lot of counterindications that can occur, such as red man's disease. You can have kidney failure. You can go through rashes, have a lot of kind of different reactions. And unfortunately, this is something that definitely needs to be monitored, especially when given IV antibiotic of vancomycin. VAP is a leading cause of nosocomial pneumonia. This disease occurs worldwide in ICUs, but it is seen at higher rates in lower and middle income countries due to the hospital having limited infection control resources. Approximately 49,000 of pneumonia infections occur per year, and 28,000 of those are from mechanical ventilation. According to the American Thoracic Society, Volume 18, mortality rates go up to 50% once a patient is diagnosed with VAP. This is mostly due to the organism's ability to be multi-drug resistant. In neonatal units, this is the second most common nosocomial infection. VAP is not a traditional contagious disease like the flu or the common cold, although it is communicable, especially in the ICUs. VAP is not airborne. Often contaminated equipment such as hands of healthcare workers or contaminated ventilator parts causes the spread of the disease. Patients that have certain comorbidities are at a higher risk for VAP, such as COPD, diabetes, chronic kidney disease, heart failure. In addition, those who are immunosuppressant or have neurological disorders are also at a higher risk for VAP. The initial start of VAP typically occurs within 48 to 72 hours after intubation. The bacteria are entering the lower respiratory tract and shows no symptoms at this phase. During the second phase, this is when symptoms begin, such as fever, increased respiratory secretions, pulse ox decreasing. If a chest X-ray was to be done at this point, it may show new infiltrates and an increase in white blood cells, and the CBC would be present. This is when antibodies should be given, antibiotics should be given, and careful observations must occur. Phase 3 is the most severe sign, showing lung inflammation, impaired gas exchange. At this point, the patient may need higher ventilation support and more oxygen. If this disease at this phase goes without proper treatment, the patient may have sepsis, go into septic shock, have acute respiratory distress syndrome, and multi-organ failure. This is when mortality risk is at its peak, and immediate action must be taken in many forms to address the several system impairments occurring. The goal is to not allow the disease to get to this phase, as treatment at this stage is incredibly challenging and effects of it can be irreversible. The prognosis of ventilator-associated pneumonia is highly dependent on when it is recognized and treated. In addition, it is dependent on the patient's overall health and the microorganisms specifically causing the VAP. Mortality rates, as previously discussed, go up to 50%, with critically ill patients being the less likely to survive. When the bacteria is antibiotic resistant, this also plays a huge part in the patient's ability to recover. Patients that received appropriate care during phase 2 of this disease show 70 to 80% chances of survival. Therefore, early detection and treatment is life or death with VAP. Understanding the prevention, risk factors, symptoms, and early treatment is critical for the survival rate for VAP patients.
Scientific context and background. Ventilator-associated pneumonia is a serious nosocomial infection that develops 48 or more hours after mechanical ventilation. VAP is associated with an increased mortality rate, longer hospital stays, higher healthcare costs, more antibiotic use, and the development of antibiotic-resistant microorganisms. In the literature, the incidence of VAP ranges from 8% to 28.8% of the population at risk, with event rates ranging from 1.4 to 16.5 per 1,000 ventilation days. Risk factors: advanced age, chronic lung disease, immunosuppression, neutropenia, which is a decreased amount of neutrophils, dysphagia, difficulty swallowing, and recent thoracic or abdominal surgery. Common pathogens associated with VAP include Staphylococcus aureus, Pseudomonas aeruginosa, Klebsiella species, Streptococcus species, Enterobacter species, and Candida species. Studies have identified that severe underlying disease, high APACHE-2 scores, COPD, and infection from multi-drug resistant organisms are associated with an increased mortality rate in VAP patients. Does the implementation of VAP prevention bundle reduce the occurrence of VAP in ICU patients? Does the prevention bundle improve patient outcomes like mortality rate and complication? What factors are associated with mortality among patients who develop VAP? And the authors did not explicitly state formal hypotheses, but their objectives suggest they predicted or theorized that the implementation of the VAP prevention bundle would decrease VAP incidences and improve outcomes. They also theorized that certain clinical characteristics and risk factors would be associated with increased mortality. The overall goal of the study was to evaluate the effectiveness of VAP prevention measures and to ID or identify factors that determine patient risk.
This study looked at adults over the age of 18 who were on mechanical ventilation for more than 48 hours and focused on cases of VAP. Only the first occurrence of VAP per patient was included. VAP was diagnosed based on a chest x-ray, in addition to changes along with symptoms like fever, abnormal white blood cell counts, pus, and respiratory secretions, or reduced oxygen levels. Cases were categorized as early onset or late onset, depending on when they occurred after ventilation began. The study also identified sepsis and septic shock using standard clinical signs like abnormal heart rate, breathing rate, temperature, and blood pressure. To confirm infections, samples were collected via the lungs or the blood. Researchers used scoring systems such as SOFA and APACHE-2 to measure how sick patients were and how their organs were functioning. A prevention bundle was implemented in the ICU, which included proper hand washing, checking daily if ventilation was still needed, giving breaks from sedation, keeping the patient's head elevated, and maintaining cleanliness. Healthcare workers were trained on these prevention steps, and compliance was regularly monitored. Data for the study was collected from patient records and analyzed using statistical software, and the results were presented as percentages or averages.
For our results, a total of 83 patients with VAP were in this study. The charts include patient characteristics, comparison of pre-bundle and active bundle periods, comparative characteristics of VAP patients with death versus survival. Our table 1 here, for a little summary of it, the average age of participants was 69.4 years, and 48.2% of the participants were female. The average APACHE-2 score at ICU admission was 17.8, while the average SOFA score increased from 4.3 on admission to 5.9 at the time of VAP diagnosis. Among the patients, over 23% developed early onset VAP, 55% developed sepsis or septic shock, 39% developed secondary bloodstream infections, 55% developed ARDS, which is acute respiratory distress syndrome. 59% died within 30 days. This is a very lethal disease here. The most frequently identified pathogens were E. coli, Acinetobacter baumannii, Klebsiella pneumoniae, Pseudomonas aeruginosa, which is our pathogen here, and Staphylococcus aureus. Things to make note of are how high some of the complications are. The mortality rate within 30 days being 59% is high. So is the sepsis rate and the ARDS rate, both being around 55%. So this chart here, our method connection, is the researchers collected demographic, clinical, laboratory, and microbiological data from all the patients diagnosed with VAP in this study. They measured variables like age, APACHE-2 score, the SOFA scores, laboratory values, and infecting organisms or our pathogens. And the results connection to this was that our table here presents the baseline characteristics of the study population and shows the frequency of complications like sepsis, ARDS, bloodstream infections, and mortality, which were all quite high. This describes the overall VAP population that was analyzed throughout the study. Here we have our table 2 from results here. The study compared outcomes before and after implementation of the VAP prevention bundle. VAP incidence decreased from 19% to 17.5%. VAP rates per 1,000 ventilator days decreased from 4.9% to 4. Early onset VAP decreased from 26% to 19%. The incidence of sepsis or septic shock remained similar between the groups, though, so that didn't change very much. Secondary bloodstream infections and ARDS occurred at similar rates in both periods. They didn't change much. The distribution of bacterial pathogens also remained unchanged. Mean hospital length of stay was slightly longer during the active bundle period, and 30-day mortality increased from 52.2% during the pre-bundle period to 67.6% during the active bundle period. But the analysis showed that none of these differences were very significant. Our method connection here is one of the primary study objectives was to compare outcomes before and after implementation of the VAP prevention bundle. The researchers divided patients into a pre-bundle group and an active bundle group and compared VAP incidence, mortality, complications, and pathogen distribution. Results connection to this table here shows the outcome of that comparison. The data indicates that VAP rates, early onset VAP, mortality, ARDS, bloodstream infections, and pathogen distribution were similar between the two groups, meaning the measured outcomes did not significantly differ after bundle implementation. So for table 3 of our article, we have the results of mortality analysis and risk factors. So patients who died within 30 days were compared with those who survived. Compared with survivors, patients who died had higher Apache 2 scores, higher SOFA scores, higher rates of sepsis and septic shock, higher rates of secondary bloodstream infections, longer duration of mechanical ventilation before the VAP diagnosis. They also had lower lymphocyte counts, lower albumin levels, higher C-reactive protein levels, and there were more frequent central line catheter use. The duration of mechanical ventilation was significantly longer in the death group, recognized risk factor associated with increased exposure to the antibiotics and selection of drug-resistant pathogens. The method connection would be the researchers also wanted to identify factors associated with mortality. To do this, they compared patients who survived with patients who died within 30 days after developing VAP. The results connection is this table here displays the differences between survivors and non-survivors. Variables such as the Apache 2 score, SOFA score, sepsis, ventilation duration, lymphocyte count, albumin level, and CRP level were compared to determine which factors were associated with mortality. We have our table 5, which is a analysis that was performed to identify independent predictors for 30-day mortality. It identified that lymphocytes and albumin were lower, and they showed a higher mortality rate as independent predictors of mortality. And they were very significant in the results. Our method connection here with our results connection is researchers use multivariate logistic regression analysis to determine which factors independently predicted death using information from our table 3. Table 4 here shows the variables that were the most significant from table 3 and the research done for that.
Now we're going to go into the article discussion. This study found that VAP is still very common in ICU patients linked to high death rates. As Gracie had previously discussed, early onset VAP occurs frequently and mortality within 30 days was high. Many patients with VAP also develop sepsis or septic shock, which increases their risk of death. The VAP prevention bundle used did not significantly reduce infection rates or improve patient outcomes. Early onset VAP rates stayed about the same, suggesting that the bundle didn't effectively reduce certain risks like aspiration. The types of bacteria were similar before and after prevention. The prevention bundle didn't change which bacteria were present. Possible reasons the bundle wasn't very effective include poor compliance, weak infection control practices, and antibiotic resistance. The study showed that many of the patients who died were generally sicker, with high severity scores and much higher rates of sepsis compared to those who survived. Overall, the results showed that VAP remains a serious problem, and better prevention and treatment strategies are still needed. The questions we have are tailored around the belief that we, as healthcare workers, are the future. So let's discuss some topics on what we can do to do better in regards to technological advancements or personal responsibilities for prevention of VAP. Our first question we would like to ask you is what emerging technologies should be investigated further to prevent VAP? Some questions that may help your mind start thinking is, should we have antibiofilm coatings on endotracheal tubes? Could AI assist in early detection? The second question we would like to ask is, if VAP is mostly preventable, why is it one of the most common nosocomial diseases? Is it proper hand washing not being followed, lack of oral hygiene care, lack of knowledge of this disease, and therefore lacks early detection? lack of following proper ventilated protocols for the patients due to short staffing issues. Thank you guys so much for your time, and we hope you enjoyed our presentation.